Today we're going to be talking about nasogastric tubes and their insertion. We're experimenting with this audio so that you'll be able to review it online a couple of times before you come into class so that we can spend more time actually doing the practice of the skill in our practice lab. The nasogastric tube is usually placed for one or two reasons into the GI system. First, there's some kind of an obstruction somewhere below the stomach. Don't forget the stomach is an organ. I am not talking about the abdominal area. Secondly, there may be some kind of an issue with the area above the stomach that places the patient at risk for aspiration of stomach contents. Therefore, let's have a little bit of a brief review of the GI system. The GI system is responsible for the essential bodily functions. It takes care of ingestion, propulsion, and digestion of food. It's also responsible for the absorption of the nutrients that come from that food, plus storage and then finally elimination of the waste. So remember, as I said to you back in 110, it's important that you have your Taber's book and your anatomy and physiology book with you whenever you are studying and reading your book and even listening to these audios, so that if you have any questions, you can refer to them. The GI tract is also referred to as the alimentary canal. Don't forget what I said. Everything in healthcare has to have more than one name. So the alimentary canal, along with its accessory organs, it starts at the mouth, continues down through the pharynx, the esophagus, the stomach, and then enters into the small intestine at the area known as the duodenum. The rest of the small intestine is called the jejunum, and then finally the ileum. Then it passes through into the large intestine or colon, and that's referred to as the ascending because it's located on the right side of the abdominal wall, the transverse coming across the top of the abdominal wall, the descending, and then into the sigmoid area, followed by the rectum and the anal opening. So we're shortly going to discuss some of those varied reasons that we talked about regarding NG placement. As you can see with a cross view of the NG area, you're looking at the nares, followed by the pharynx down the back, and then eventually the esophagus. You'll see that the epiglottis is over the area that will protect the trach. And then you see, if you look at the second picture on there, it does point to the stomach organ itself. So a nasogastric tube is a pliable tube that is inserted through the nares and then down the pharynx through the esophagus and into the stomach. This allows then for contents that are blocked to be removed through this tube. Since they're not able to move for whatever reason, either downward because there's some kind of a blockage, and we don't want them to come upward. So since they can't move, we want to eliminate distension for the patient and give the problem area time to relax and possibly even repair itself. Important nursing interventions. Once the tube is placed, it is always important that you remember to monitor the patient's nose and oral cavity to make sure that we are preventing any possible breakdown or damage. Again, another picture of the area of the NG. What are some of the reasons for placement? Post-op major surgery, treating mechanical obstructions, decompression, as you can see here, diagnostic studies, irrigation, or administration of meds or feedings. So post-op abdominal procedures, the bowel will need to relax. Anesthesia has to press the normal peristalsis, and depending upon the reason for the surgery, the patient may need the tube to give the area time to reestablish movement. This will then help prevent any kind of nausea and vomiting from occurring. Just a simple reminder, when they are placed by the OR, the doctor will give you some additional specific instructions regarding their care. Mechanical obstruction. Various causes from scar tissue formation over an area of the bowel to some kind of an inflammatory process, a hernia, a volvulus, a tumor, an intussusception, anything that is involved with some kind of an obstruction. These are things, and we'll talk about them shortly, that need to either be repaired or need to be decompressed for a while so that repair can take place. When you're looking at the intussusception, and that's where a part of your intestine, usually the small intestine, has slid inside of itself, that can be a major problem, and you usually see that predominantly with infants, with neonates, with little babies. Okay, with decompression, for some reason something's blocked and it won't pass downward through the GI canal, so it can be fluids and or gas, so we just want to decompress and allow it to relax itself and then come back up into work. Now, if you're looking at diagnostic studies and obtaining specimens, sometimes the tube is needed to instill medications that may either be uncomfortable to swallow or that can irritate the esophagus. Maybe they have a foul taste, whatever the reason. Or it may be to obtain some kind of very specific stomach contents for diagnostic purposes. When you're looking at lavage and irrigation, usually we're looking at someone who either has an overdose or has a GI bleed going on. Most often anymore with GI bleeds, the patient is taken immediately to the OR. There are times, however, when we need to do a lavage of an ice solution to help slow down the bleeding. But for an irrigation, and we're looking at someone who is overdosed, we'll place the tube in because we will instill sometimes chemicals that will help to combine with whatever was absorbed, ingested, and then after that you will have the need to remove it without it doing damage to the esophagus. For feeding or for medications, something has occurred above the stomach area, and we do not want anything to aspirate into the lung cavity. So we will be able to place the tube to give them nutrition while things are determined what's going to go on. And this is usually a temporary bypass area. Here's some of those mechanical obstructions that I had mentioned previously. The picture shows some of those disorders. You're looking at an adhesion where scar tissue is wrapped up or overlapping an area of the bowel. B, if you haven't guessed it, is a hernia where you've got an abdominal wall that is weak, and so therefore the intestine is protruding through it and thus making it difficult for the easy continuation, propulsion of food through the colon. Letter C, you're looking at a tumor. There is some kind of a growth that is making it slow to pass through or totally blocking it off. Now, C can be either benign or malignant. D is that intussusception that I talked about, and as I mentioned earlier, it is rare in an adult. It's more common with babies. And usually just allowing the area to decompress will cause that tissue to slide back out, and then the colon itself will repair itself. And then lastly, you're looking at E, which is a volvulus. And a volvulus is actually where the bowel has twisted over on itself. Now, most often, once it is decompressed, that might flip back over on its own. Sometimes what happens is the doctor will be able to go in once the area has been decompressed for a while, and will be able to go laparoscopically and flip it back to where it needs to be so that they don't need to do a very intense invasive procedure. So now let's talk about the two different nasogastric tubes. The Salem sump gastric tube is going to be the primary tube that we are going to be talking about, but I do want to mention the Levine tube briefly. Now, the Levine tube, these are two of the most common tubes that are used. The Levine is a single lumen tube mainly used for medication and food administration. They are, as I said before, temporary, and they usually vary in size depending upon the size of the GI canal. I will have some different tubes out there in the classroom for you to check out. They are single lumen, therefore they cannot really be used to decompress or, to connect them to suction. And we'll talk about the reason why that doesn't work that well with them. And as I said before, they're usually just completely used just to give administration of meds and food. The Salem Sump gastric tube, however, is a double lumen tube. It is much less pliable than the softer Levine tube. It is most frequently used for patients that need suctioning, whether it is contents or just for decompression. The sizes are usually going to be noted with that capital F, lowercase r, the French letters next to it. If you remember when we were doing urinary catheters last semester, they're measured the same way in terms of with that French denotation. Sizes for adults are usually 12 to 14. If a specific size is requested for the patient by the healthcare provider, the healthcare provider will make a notation on the order. And there are various sizes again for these, so I will have them also available, the ones that we do have here, so that you can look at different ones. Most often, though, as I said, we usually use between a 12 and a 14 for the insertion into an adult. And sometimes it does depend on the reason for the placement. If it is just for the decompression because of gas and maybe some thinner fluid, then the doctor may want you to put in a smaller tube. But if there are larger particles, some kind of a blockage where the content may be larger, they may ask for a larger tube to be in place. Now, as I said, there are 2 lumens with the Salem Sump, and that's necessary because they are placed to decompress or to remove contents. The first lumen, which is the clear port, will drain the contents. This is the port that will allow for decompression, while the blue port, which is frequently referred to as the air vent, allows for safe suctioning. The tip of the clear tube will not adhere to the stomach wall as long as that blue port or air vent is unblocked, and thus preventing any kind of damage to the stomach mucosa. The blue air tip then is never ever to be irrigated with any kind of liquid. Never. It should always stay above the abdominal area to prevent any kind of increased pressure within the abdominal cavity. If it is left lower than the stomach area, fluid may inadvertently back up into the blue port, and then it will no longer function as the air vent is meant to be. At the very end of that blue port, we usually place a white and blue cap, which is referred to as an anti-reflux valve. And in that cap, which you will see in the classroom, there is a piece of filter paper in there, and it allows for air to come through the little holes that are visible in that anti-reflux valve and air to pass out. So therefore, it allows for movement in the stomach cavity, in the stomach organ, for the bottom of that tube, so that it never sticks to the stomach wall. If for some reason you have the tube itself, you begin to see fluid backing up into it, a nursing intervention that you can try, as long as the liquid has not reached that anti-reflux valve, is to take a 10 milliliter syringe, instill air into it, and try and push the fluid back down through the tube. The other option, and also if you suspect that that paper within the on the anti-reflux valve, that cap, has become damaged, take it out, replace it with a new one. If nothing works, then usually the best option is going to be to remove NG tube and to replace it with a new one. And being as this can be extremely disconcerting for the patient, we try our best to make sure that that blue port does stay above the chest area. Now, I just want to take a moment to mention a few other tubes that you may see. Unless you're in a specialty area, you may not see these as often. They're not used as frequently as they used to be because patients do tend to go to the OR with different situations much faster. But some of them are. The first is called the Ewald tube, EWALD, and it's used to irrigate and clean out or flush the stomach with certain overdose victims. The second is called the Senstagen Blankmore esophagus tube. Now this has 3 lumens, and the reason for the third lumen is so that a balloon will inflate in the esophagus and gently extend against the esophagus wall. The reason is for esophageal varices. Remember that esophagus is a very thin wall. The blood vessels are very close to the surface. With patients, for example, that have chronic vomiting or that are chronic alcoholics, that esophagus wall does weaken, and those thinned blood vessels can very quickly rupture and cause bleeding into the esophagus, into the stomach. So that lumen, that third lumen, will inflate a balloon around the esophagus and compress it gently so that it will be able to stop the bleeding. It's just like a pressure dressing. Now, if you have the last tube I want to mention is referred to as the Minnesota tube. If the patient does have a Minnesota tube, the difference is only going to be that this tube has a 4th lumen. It is used similar to that Senstagen Blankmore. We usually just call it the Blankmore, but it has the added port which allows for suctioning above the esophagus, above that esophageal area. So, and you'll also see different things referred to as nasoenteric tubes, and they're usually passed down into the small intestine, so therefore they are longer in size. Also with that Blankmore or the Minnesota tube, there is also an area that will not only inflate in the esophagus, but another area, portion of the balloon, will inflate at the top portion of the stomach cavity to allow it to stay in place easier. So now let's talk about the equipment that's needed, the actual nursing procedure. In most facilities, only the RN is allowed to insert a nasogastric tube. However, there are some areas or some departments in specific facilities where the licensed practical nurse, the LPN, can place the tube. So the first thing you're going to need, depending upon the size, will be the nasogastric tube, that Salem sump tube itself. You want to make sure that you have water-soluble lube gel, KY gel, whatever you want to call it. You're going to need a safety pin, a basin, a towel, or an incontinent pad. You're going to need clean gloves. This is not a sterile procedure. You will need water in a cup with a straw if necessary. Some nurses do not use it to insert the tube. Others do, depending upon your preference and the patient's preference. It does help if you have a cup with water in it and a straw for the patient to take that when you're starting to advance past the oropharynx area, because then the patient, first of all, is concentrating on swallowing, and secondly, the swallowing allows for easy advancement of the tube. Again, though, it's a preference. Okay, you want to make sure that you also have sterile 60 milliliter syringe is usually the correct syringe with the correct catheter tip. Sometimes you can use the irrigation equipment and the syringe will come with it. Sometimes you will just get a container or a bowl. Either one, you will need sterile saline, most often is what is ordered. Some facilities will use sterile water, but we are moving to sterile fluid to make sure, instead of tap water, that there is no no introduction of any kind of bacteria or so into the GI tract, even though it is not a sterile area. You will need non-allergenic tape, at least an inch wide, or pre-manufactured nasogastric tube holders, depending upon your facility's policy. I know you're tired of hearing me say that, but you always, always, always must check the policy and procedure manual of your facility. Another thing that you may need is pH test strips, because you're going to want to check the pH of the content that you aspirate from the stomach. Anything that is in the stomach should be highly acidic. So usually you're going to have a pH of less than 5. If you have 6, around 6 or a little bit above it, chances are it may have gone down a little bit past and has entered the duodenal area of the small intestine. If it is greater than 7, chances are you have gone through the trach and it is now in one of the lungs. However, there are other signs that can indicate that it is in the lung cavity. Usually continual gagging and unexplained coughing lets you know that it has traveled through the trachea and is now somewhere in the respiratory tract. You are also going to need the suction source. That means the suction canister, possibly even the meter, the connective tubing, anything so that it can be set up and connected to the wall unit for suctioning if the suctioning is ordered. Now, per your book, and I think it's on page 890 in your book, it does discuss low continuous as well as low intermittent suctioning. The main numbers that you have to remember are usually between 80 and 120 milligrams of mercury. For low continuous, they're going to want it between 80 to 120. For low intermittent, your book states 80 to 100. So as I said, just think in terms of 80 to 120, and we're talking completely about wall suctioning. If you are using some kind of a table device, it will vary differently because of the type machinery. You must always check the policy and procedure manual of your facility. The skill itself that I'm discussing with you now is in your kosher book starting with page 1284. So please make sure that you do review it so that you are able to come in and we can just gather equipment and get to the bedsides in the practice lab and begin to complete over and over this skill so that you are comfortable with it. Next, when you're going to measure the tube, depending upon your facility, most will tell you from the nose tip to the earlobe, from the earlobe down to the xiphoid process. Then add anywhere from 1 to 3 inches. The average adult length when you are looking at it is about 22 to 26 inches for the length of the tube, or roughly 55 to 66 centimeters. There are traditionally, as I said, the tip of the nose to the earlobe, but if you're looking at the, depending upon your facility, if you're looking at, for example, Geisinger's, they say from the earlobe to the bridge of the nose, and then from the bridge of the nose to the xiphoid process or the breastbone. And then they encourage you to add up to 3 inches. So either way, I've always been taught, and the way I always teach it is nose tip to the earlobe, earlobe down to the xiphoid process, and then add an inch or 2. You want to make sure that you get past that cardiac sphincter if you're looking at the picture that's on the screen now. Another one that you can look at is at the 50 centimeter mark. Just pick about halfway between the two marks. You're going to see on the nasogastric tube, on that Salem tube, black markings on it, and it's showing you different centimeter markings. Once you've determined the length, it is always a good thing to take a piece of tape, especially when you're just learning the skill, and flag that area so that you know how far in this tube needs to go so that you can guarantee that you are in the stomach cavity. Now, once you have gathered all of your supplies, make sure that you wash your hands. You've heard me say enough times, the first thing you do before any skill is to wash your hands. When you get into the patient's room, you make sure that you identify your patient using your two identifiers, name and date of birth. You want to provide privacy, adjust the bed height for your comfort. Don't forget, if you have the patient down in the lowest position, you're going to be bending down to reach the patient, and the only person that's going to have a problem is you with a sore back. So you want to elevate the bed itself to be comfortable for you. You can be explaining the procedure while you are doing this. Then you're going to put the head of the bed up. Position them in high fallers with the pillow under their head. We're going to talk about it when we get into the lab. Because we're using mannequins, it's easier when we're doing the mannequins to remove the pillow. So after you've measured the distance to insert the tube and you have now flagged the tube, now remember this is a clean procedure. You're going to put that incontinence cloth or the towel out on the patient so that you can basically use it as your little area to work with. Again, if I didn't mention it before, and I apologize, I'm going to remind you, make sure you bring a basin. Now, some facilities tell you to bring that little emesis basin. I suggest that you bring a big basin, depending upon how obstructed, how distended they are. Once that tube goes in, it's like rupture, and it gets through that cardiac sphincter. It's like rupturing a balloon, and all kind of content can come out through the tube but also around it. So you're going to now assess the nares for obstruction. Now when you're assessing the nares, you also want to be questioning the patient. Some of the first things you want to ask them are, have they ever had this tube before? Have they ever had any kind of surgery on their nose? Were they ever told they have a deviated septum? Have they ever had any kind of issues with their nose? So you look and ask them which side they breathe out of better, because that'll make it easier for you to place it. Once you have the position, the patient positioned correctly, you've assessed it, you've occluded, you can even press on each nostril and have them breathe from the other side to determine which is better. You want to lubricate about 3 to 4 inches of the end of the tube. Again, remember, this is not a sterile procedure. This is clean. You're going to have them extend their head backwards. You want them to hyperextend their head back. That allows for straightening of the oropharynx area. You want to gently insert. You never force the tube. So you want to gently insert the tube, aiming toward the floor, the nares, and allow it to begin to go down around the curve of the oropharynx. Now, prior to doing this, prior to even lubricating it, because as I said, the Levine is pliable, whereas the Salem sump is not. It's more of a tougher plastic or silicone. I usually roll it in my hand a little bit, and we'll discuss it in lab, but I usually roll it around a little bit to soften it up. Some books do suggest that you can soak the first 6 inches or so in warm water. By the time you do, so a lot of times you're not going to have time to do that, but you do have different options. I usually just curve it a little before I lubricate it. So you want to gently place it in. And once it reaches that pharynx area, you're going to tell the patient to hold their head either in normal, or we usually suggest to have them bend their neck forward. At this point, Once they flex their head forward, you're going to encourage them to sip on that cup of water, and you're just going to steadily insert the tube until you reach the point that you have marked with tape. Now, should you meet resistance, pull it out, allow the patient to rest, attempt to insert it again. If necessary, try the other nares. Now, if they're just giving you a rough time, you don't have to take it all the way out. Explain to them that it's uncomfortable, the procedure, but once it's in place, it's going to be a little uncomfortable while it's in there, but that it is there for their benefit. If the second time you're trying to place it, you're using the other nares and you are still meeting resistance, you first of all never ever ever force, and secondly, after 2 attempts and you can't do it, you call the hospitalist, the healthcare provider, either the doctor, the nurse practitioner, whoever is taking care of this patient. Okay, so that once it reaches the pharynx and they've got their head forward and you encourage them to swallow, you shouldn't have any other issues. However, if during this point they start violently coughing, again, as I said to you before, this is indicating that this tube is probably in the trach. It's in the respiratory tract. Remove it. Now, once the tube is at that measured mark, you want to secure it gently to the nose. Now, you have a couple of options. You can clean their nose if it's extremely oily or so prior to doing this with an alka pad or so. You can even put some skin protectorant on it, which will make it a little sticky so that the tape will adhere easier, but you want to gently secure it, not so that you don't want it to be able to move, okay, but you want to gently secure it so that you're also not pulling their nares up, because it will cause breakdown of the tissue very easily. Now you're going to assess for tube placement. This first one, which says to aspirate gently back to obtain some gastric content using that catheter tip syringe that you brought in with you, is truly, when you're doing it, you're aspirating and you're looking at the contents, is truly a way to see the coloring of the content. It doesn't really guarantee, though, that you are in the stomach. It can say that you are in the intestine, and it can be some drainage coming from into the trachea. But you want to look at it and you want to check it for that pH. If it is, now I have less than 4 on here, your book says less than 5, chances are it is in the stomach. Also, if it looks golden or if it's bile colored, if it is green, if it is, we don't want to see it as red or brown colored, coffee ground colored, because then we're looking at fresh blood or old dried blood. But if you see any kind of thing like that, chances are you know that you're in the right place. The only guaranteed 100% it is confirmed is a portable chest x-ray. Almost every facility mandates that you must do a portable chest x-ray if you are instilling meds or tube feedings. Another test that some facilities still have in their policy and procedure manual is to instill 10 to 20 milliliters of air into the tube when you first place the tube before you aspirate back for any of the stomach contents. So usually I will put the 60 milliliter syringe with about 10 milliliters of air at the end of the clear port of the Salem tube. And then if you put your stethoscope on the left upper quadrant, right about 2 inches below and 2 inches to the left of the xiphoid process, you can gently hear a whooshing sound when you instill that little bit of air. But it could also be in the respiratory tract and you're still going to hear the air. So it's truly a basically useless test, but some facilities still utilize it. But as I said before, your guaranteed placement will be the portable chest x-ray. Now, depending, as I said earlier, if it has been placed in surgery, it's been verified by the surgeon. They don't need another confirmation with another x-ray once they get to the floor. And the doctor will usually note in their orders that they placed it, everything was done, and the length of it, and it will be marked. So you just do not need to pursue further. Once you guarantee that it is in place, you're going to make sure that you secure it firmly to the patient's nares with that tape to the top, to the nose, giving it enough movement so that it is not pulling on the nostril. If you're using a pre-manufactured holder, secure it in place. Then you want to come down about 10 or so inches from where it's placed in the patient's nose, and you want to secure a piece of tape onto it, and then taking that safety pin that you brought with you, you want to secure it toward the shoulder area of the patient's gown, thus guaranteeing that the ports will remain above the abdominal wall. Once you do that, if it is scheduled to be connected to suction, you can connect it to suction per the facility's policy. If you brought in what's called a Lopez valve, which is a three-way stopcock valve, and I will show them to you in lab, that usually can be connected to the end of that clear port, which then allows you to not have to constantly be maneuvering the tube itself. You would just turn the dial on that valve to be able to test content or to instill medications to do whatever's necessary. Once it's secured in place, you make sure the patient is comfortable, and then you're good and you're going to monitor them. Now, if you're taking this tube out, a lot of times the doctor will suggest prior to tube removal that you, as the nurse, assess their ability to withstand its removal. So sometimes the doctor will tell you to clamp the tube and shut off the suctioning and that for half an hour or so, see how they tolerate it. Some facilities, some doctors will say to you, okay, we'll give them one or two of their medications that are able to be crushed and instilled through a tube and see how they tolerate medication in their stomach. Once you are giving them any kind of medication or so, remember, you can never instill something and then just connect it back up to suction. Critically think, all that's going to happen is the medication is going to be sucked right back out. So if the doctor wants you to give them a medication to see how they're going to handle getting this tube out, you automatically clamp the tube for at least 30 minutes to allow the medication to be absorbed. If during that time the patient complains they can't tolerate it, then you connect it back to suction and you notify the doctor. If everything, however, is going okay and you're able to remove the tube, always double check the order, wash your hands, identify and assess the patient, and explain the procedure. You're going to raise their head of the bed to a semi-Fowler's position, turn the suctioning off, and loosen the tape. Give it one final check of placement by putting in 10 to 20 milliliters of sterile normal saline. That is going to be, and the checking for placement there, I usually put a little bit of air in just to hear the swish, or I may take a little bit and check for the pH if it's ordered, again, per facility's policy. But when you instill the saline, the purpose is to get that stomach content back in the stomach now. We no longer want to be suctioning this stomach contents out. You want to make sure that everything is back into the stomach and also that none of it is dripping out the end of the tube as you are pulling it out because it's going to leave an uncomfortable taste in the patient's esophagus. Once that's all been determined, you can completely remove the tape, pinch the tube, or if I have the syringe on it, sometimes I just leave it, or clamp the tube, because the last thing you want is for them to be sucking in air, atmospheric air, and gently but quickly remove the tube. You can tell the patient to take a deep breath and hold it, and you pull the tube out slowly and steady. You don't just yank the tube out. You gently but steadily pull it out. It usually takes you about 3 seconds or so. Once you've done that, you're going to provide hygiene not only in the nostril area, but also the oral area. Remember, even though the patient has two nares, they're going to tend to mouth breathe the whole time this tube is in place, so that their mouth is going to constantly be dry. So make sure that they get frequent oral care, and also from this being in their nose, they may have dry nares in that. So you want to always be careful to watch to make sure that they're not having any skin breakdown. You've provided oral care, mouth care. Please do a good assessment to make sure there is no breakdown, and then document the entire procedure and how they tolerated it. Now, just to talk a little bit further about a PEG tube, as you can see on this slide, and a little bit about enteral feedings. Remember, when you have a patient, as I said, that is in danger of aspirate, the tube itself, the NG tube, is usually going to be temporary until the doctor has decided that it needs to be removed and they need a permanent feeding. If that's the case, then the tube is going to be placed just as you see here, through endoscopy, through the abdominal wall, into the abdominal organ, the stomach itself, into that stomach. And it's going to be held in place with a balloon similar to what you saw with urinary catheters. Therefore, it is permanently placed within the stomach cavity, and it is easy to do your feeding, as we discussed in 110 when we were talking about medication administration. The important thing that you must always remember when the patient has a PEG tube is, whatever reason the tube is in, is dedicated to the fact that something above that cardiac valve, that sphincter at the top of the stomach, going to the esophagus, is no longer working correctly, so that this patient is at high risk for aspiration. Therefore, never, ever, ever should this patient be placed in a flat position. They should always be up at least 15 degrees. They should never be getting their tube feeding while they are in anything but semi-Fowlers, which means 30 degrees to above. Because if you lower the patient, they are going to aspirate the content into their lungs. So always remember that. And the other picture shows you where the nasoduodenal tube may go, the gastrostomy tube, or even if it's placed in the jejunum itself. So those are pictures to show you, and there's information about it within your readings. Lastly, just to mention again, we had already talked about this in 110. As you can see here, these are bags that are going to be hung usually for a long time frame, anywhere from 10 hours to 20 hours. A lot of times now what doctors are ordering are bolus medications, bolus feedings, where the patient might get a can of their supplemental feeding about 5 or 6 times a day. And then this way they're instilled very quickly, just like you normally eat. You don't normally eat continuously over 20 hours. So they'll get their bolus, and then that has to be absorbed. If we're doing that, same stance. You should never have that patient laying flat once they've received that bolus feeding. Okay, so I know that this has been lengthy. It's going to last you about 45 minutes. I hope that you are comfortable with listening to this. You can listen to it a couple of times so that you understand it. Make sure that you understand the nursing responsibilities for the placement and for the removal of the nasogastric tube. And I look forward to seeing you in our campus lab for week 5.